Welcome everyone to the fifth session of our Research Integrity and Ethics series. In this session, we are going to focus on research involving human participants in biomedical research and social science research. So thank you so much for taking the time to join us today, and we hope that you're going to enjoy the discussion and just learning more about the ethical standards in terms of human research. We are privileged to have the chairpersons of our Human Research Ethics Committee sharing the expertise with us today. We have Prof Mariana Kruger, who is one of the chairpersons of the Stellenbosch University Health Research Ethics Committee, and Prof Ilana van Wyk, who is the chairperson of the Social Behavioral and Education Research Ethics Committee. And they will be speaking to us specifically about the history, principles, and the benchmarks of ethical research involving people and all their information. So, house rules, we ask that you please keep your cameras and your cameras off and your microphones muted during the speaker presentations. We will take questions at the end of the session just so that we can manage time effectively. But you are welcome to post your questions or comments in the chat if you would like us to just keep it as a placeholder to the end. Also, to those attending who are registered with the Health Professions Council of South Africa, if I could ask you to please send me an email with your registration number so that we can keep this on record for possible CPD points. So I'm going to post my email in the chat, but in the meantime, I'm going to ask Prof Ilana van Wyk whether she can share her slides and start us off with the presentation. Thank you so much, Prof Ilana and Prof Mariana.
Thank you, Clarissa. So I'm just going to, colleagues, now, of course, as you know, as one starts, this is usually when things go wrong. So I hope, there we go. Thank you very much for the opportunity to talk to you today, and specifically around the background to what it is to do research ethics at our university, and specifically in South Africa, research that deals with humans. So I want to take us back a little bit to where it all started and where scholars started talking about this new thing of applying for research ethics through the kind of committees that I chair and that Mariana chair for health research. So I'm going to take you to my field. I'm an anthropologist, and to one specific woman who is very well known in our field, specifically looking at this. Looking at ethics, and what she and a number of other social scientists said in the 1990s was that we started seeing a pervasive practice of accountability. So suddenly, something that wasn't before the case, we saw enormous amount of attention being paid in universities to practice of accountability. And she said these are evidence of so-called audit cultures. And she said these audit cultures invade almost every part of our lives nowadays. And what it means for specifically for universities and for academics like ourselves is that we started seeing an increasing formalization of what once used to be moral charters of doing research. So in the past, we were driven by our own morality. When we dealt with humans in the field, we were driven by the say-so of our supervisors. We were driven by the kind of things that were common in our disciplines, the kind of rules and regulations of our own disciplines. But suddenly what we started seeing is that we became subject to universal codes of research ethics, right? So this invasion, as many critics call it, an invasion of codes and rules and regulations, and very importantly, the rise of what became very quickly a cumbersome bureaucratic process. And I think all of you have been through these bureaucratic processes of applying for ethics clearance. And critics very often, and I was very much one of those, were very critical of this process, saying that, you know, it turned ethics into a box-ticking exercise. And this box-ticking exercise didn't take account of the messiness of research in the field. The fact that very often the applications that we fill out do not or cannot foresee the kind of things that unfold when we do, for instance, in my case, social research. So sometimes quite unforeseen things happen in the field, and this box ticking exercise cannot account for it. So, and therefore is also inadequate for the purposes for which it was designed or what it's supposed to do. Critics then said that actually what this amounts to is a form of surveillance. So this is a form of surveillance in which universities and management specifically started to impinge on what used to be the one field in which we had almost complete academic freedom. So what you did in your lab and what you did when you did fieldwork as an anthropologist, for instance, used to be something that was not subject to the oversight of university managements and committees and so on and so forth. And suddenly we have this, well, an invasion, an intrusion on that freedom. So enormous amount of critique was then leveled against this. It also meant, the surveillance also meant that large numbers of scientists, social scientists and natural scientists were suddenly subject to all kinds of disciplinary measures when they didn't meet the, well, when they didn't go through the bureaucratic process in the first instance, and when they did not do what they said they would do when they applied for ethical clearance. Now, this is all on the negative side. You know, what has happened, where we're at. But there's also something that grew at the same time. So this is in the 1990s, and this was an increasing litigation culture that started to rise in the world. So many of the people that we did research with, our participant communities and communities that we did medical research on, started to litigate against researchers who they said caused harm. So on the one hand, we have this audit culture that impinges on our academic freedoms, as some of us understand it. And on the other hand, we have an increasing culture of litigation in which participant communities are taking universities and scholars to task for real and imagined harms. So then, universities started saying that this is a way for researchers to protect themselves. So you can prove that you had done your due diligence before you started a research project, and that all kinds of risks had been mitigated for. So there's two sides of this. Now, when we look at this audit culture, and I think there's pretty much an agreement of what this is. The question often is, how did we get here? How did we get to the point where we have to be auditing ourselves and account to other academics and to university management for our work, something that we were at one stage trusted to do on our own. So what led up to this? Before I get to that, though, I want to show you the kind of auditing that happens at Stellenbosch University. So our own university is subject to this audit culture. Let me just, how do I get to the next slide? Apologies. Oh, here we go. So this is the kind of rules and regulations that govern the kind of things that REC ethics committees have to look at, and when we audit applications to us. So the first one, 1996 Constitution, South African Constitution, which governs things like informed consent and the dignity of participants. Very importantly, the National Health Act of number 61 of 2003 defined very clearly things like human dignity, autonomy, what informed consent meant, what kind of people are vulnerable when we do research and therefore needed more risk mitigation around them, what confidentiality meant, what harms mean, and also suggested or made it very clear that all research had to be both scientifically valid and it had to be beneficial for the people who participate in our research. It also had to serve the ends of justice. Now, what happened with this act was that its definition of research with humans was so broad that it started to encompass all research on humans. So at this point, up to 2003, the act, or the National Health Act, only covered research on people who, well, health research. So after 2003, with this new definition of what research with humans entailed, it started encompassing social research as well. So suddenly, anyone doing research with humans was subject to this law. We also saw in 2005 the promulgation of the Children's Act, which very clearly stipulated that anyone doing research with children had to do so subject to all kinds of rules and regulations of, oh gosh, all right. So all kinds of rules and regulations suddenly had to be, if you were anywhere near a child, you had to conform to the stipulations of this act. We also had the Medicine and Substances Act, which dealt with any human substance, tissue, those kind of things. The Consumer Protection Act, you'll be surprised to know, also governs the kind of research we can do. And the Inquest Act, for the lawyers amongst you, you might want to go and read up on that. And then I think most recently, the 2013 POPIA Act, the Private Information Act, which dealt with data protection and personal information, which had a huge impact on our on all of our research. So all of these acts started coming out thick and fast. And by 2011, the committee that I now chair, the REC SBE, Social Behavioral and Educational Research Ethics Committee, applied to the NHREC, as it's called, the National Health Research Ethics Committee, to be registered with them, so that this committee would act, would help them or guide them in doing research, audit our work, and make sure that we stick to all these new rules and regulations. So it was, on the one hand, to cover our own backsides, to be quite frank. On the other hand, also to get guidance, because the ethics landscape and the kind of auditing that started impinging on our work was just growing at an exponential level. So what happened with that then was that the Research Ethics Committee, ours, and all the others at Stellenbosch were also eventually registered with this oversight committee. What it meant was that suddenly we not only became answerable to their guidelines and directives, but that we were also declared independent from the oversight of the university itself. So what happened, well, not the oversight, but from the dictates of the university. So in effect, what happened with our registration is that all RECs at Stellenbosch became independent bodies. So we are not subject to what our deans or even the rector of the university might dictate. So it gives us, on the one hand, great freedom, but it also subjects us to a body that, as you can see, is very prolific in terms of deciding what would guide our research and what laws would apply to research with humans. All right. Another thing that happened quite recently, as you probably recall, is a number of, some research at Stellenbosch caused outrage and a lot of questions about the ethics around them. And the processes that followed these studies and the investigations led to all kinds of precedents in terms of decisions that we make. So on the one hand, we are independent, but on the other, we're subject to a national body and national laws that guide research ethics. All right. So how did we get here, and where do these laws come from, and why was it necessary to have them promulgated? And I'm going to go back to a history of ethics, research ethics with humans that, well, it precedes the 1930s, but I think it was in the 1930s and 40s that researchers in both social and medical fields realized that we cannot have a free rein, we cannot have a free hand in the kind of research that we did. And a lot of it had to do with the egregious and extremely harmful research done by both Japanese and Nazi scientists during the Second World War. And this research breached, for the medical scientists, breached all of the Hippocratic Oath dictates, that the old ethical guidelines for doctors, but also for social scientists. Many social scientists got involved in the Nazi project and tried to help the state with things like racial hygiene, as they called it. So, this complicity was something that scientists up to this point didn't have to deal with in any great measure. Even the US Manhattan Project, the project that developed the atom bomb, started raising questions amongst scientists about the necessity of having guidelines that go beyond the individual and the individual's own moral impulses. So something that stands beyond the individual and that can actually stop individuals who might not share the values of human life and so on and so forth, stop them and persecute them if necessary. In the 1950s, we also had new fields opening up. So what constantly happened, so at the end of the Second World War, we had the Nuremberg trials and the start of this Declaration of Human Rights. The basic acknowledgement of the right of humans to human life, to not be tortured, to give informed consent for research, and so on and so forth. But science and research moved at such a pace that the Convention of Human Rights actually didn't quite cover these new changes. To give you one example, in 1958, what seemed to be quite a simple little study on a small town called Springfield, what was called in the study Springfield, it seemed to be a study that was quite low risk. But what happened was the two researchers were accused of violating the town's trust, of misrepresenting the people in the town, and by doing so, causing harm. And the townspeople then suggested that this harm was unethical. And there were no ethical codes at that stage that covered this eventuality as something that an ethics committee or an ethics code would have covered. So immediately, shifting the boundaries a little bit. We also had very famously from 1957 to 1962 the thalidomide trials. So thalidomide, for those of you who don't know, was a medication used or given to women who were pregnant and nauseous, and they would take this medication, but it led to severe disabilities in the children that were born. Now, when this drug was developed, the scientists didn't anticipate such harms, very obviously. But because there was such a lag between the reporting on women who gave birth to children who were seriously affected by this drug, and the manufacturer of the drug and the scientist, it was produced for a good 5 years after the first reports came in. And the ethical question then was about who was held responsible, who should be held responsible for this damage to life, to society, to whole groups of women. All right. And again, this wasn't covered by any ethical code at that stage. 1960s, we very famously had Rachel Carson's Silent Spring. And what she did in this book was to expand the ethics beyond the lab. And she said, beyond the lab, beyond our research on, in her case, DDT, we also have a responsibility to nature and to the longer life of that which we develop. 1961 to 65, we had Stanley Milgram's obedience trials, and in which he was a psychologist, got a number of students together, and he he divided them into groups of patients and doctors, if you want, but not, he didn't call them that. But he would strap what I call a patient in, with a dividing glass between them, and would tell the doctor, or sometimes they were also called jailers, that they could give shocks to the person on the other side of the glass wall if they weren't listening. And what was shocking and life-changing for some of these doctors, jailers, were that many of them would throw the switch even after the person giving them an instruction told them that what they were about to do could kill someone. So in the aftermath of this trial, the students, and they're all psychology students, were confronted with their ability to be obedient. And many of them were very shocked that they were the kind of people who could have thrown the switch and could have killed someone, and it caused enormous psychological distress amongst this group of students. And again, the ethical codes up to this point did not cover psychological distress or emotional trauma as things that ethical bodies or researchers had to be worried about. This is something that, up to this point wasn't taken into account. In 1964, then, after all of these trials and research was done, the Helsinki Declaration was promulgated, and in it, many scientists across the world signed a declaration in which they agreed on a few basic things that all ethical codes or guidelines should include. And this included the protection of human life, health, dignity, integrity, very importantly, and you can see it with Stanley Milgram's trial, how that was threatened. The right to self-determination, i.e. the right to say no to research, and importantly, the right to privacy. As I said, the 1950s research on the small town, that research was fundamentally based on two researchers going around and eavesdropping on townspeople's conversations. So suddenly with the Helsinki Declaration, that is no longer considered ethical. People were also, under the Helsinki Declaration, also given the right to the confidentiality of their personal information. So it was no longer in the researchers' hands to decide whether and when that kind of information could and could not be shared. The 1960s was also a time when a great number of social warriors, if you want, started uncovering very unethical research. And the most famous of this, and I think some of you might have heard of it, is Henry Beecher, who uncovered the very famous and awful Tuskegee syphilis studies. So from the 1920s, Michigan University had done research on Black participants. They injected them, or either injected them with syphilis or recruited people who already had syphilis and wanted to study the natural progression of this disease. And even after a cure for syphilis was found, they withheld this cure from people in the study to not undermine the results of it. So it caused, as you can imagine, death and severe disability for particularly the men in the study. So it's largely men who participated. And this went on for a good 40 years. So extremely unethical research. In the 1970s, what we started seeing specifically in the social sciences was an enormous increase in social scientists who publicly spoke about their concerns with research, did research in places of war. So there was the famous cases of social scientists doing research in Vietnam, in Thailand, and in Cambodia. And in these situations, social scientists were starting to ask the questions about the harms that the intelligence that these social scientists gathered in these places would cause for the target communities. So very often these harms included death. And what informed consent could be secured in a situation of such unequal power situation. So when a researcher comes into a research field with a armed guard, if you want, that the question was very powerfully asked, so what kind of right or ability do you then have to say no to research? So it started questioning. So from the 1950s right through the 1970s, but in the 1970s, this question started to become the question in social science. 1978, discovery, advance in social science, in medical sciences, led us to the first in vitro conceived baby, Louise Brown, which immediately started raising new ethical questions about human tissue and reproduction. So to what extent can we intervene? To what extent can we take these human tissue when we can create life with it? In 1979, we then see the codification of informed consent across the world. So what exactly informed consent would mean in, for instance, in situations of war or in the reproduction of humans in the lab, so what would informed consent look like? The 1980s was definitely the era of debunking showing up fraudsters. Very famously, John Darcy, for medical scientists amongst you, was exposed for fraudulently creating data, and he had to retract 87 medical papers. And in this, in the subsequent years, we saw more and more scientists being found out for making up data, for manipulating their data. And very famously in 1987, a number of scholars showed that Martin Luther King, most of his PhD thesis in theology was plagiarized, and the question started asking about what do we do with this kind of work. In the 1990s, we had even more advances in medical science, the launch of the Human Genome Project. We saw Dolly cloned, and again, questions were suddenly brought to the fore that could not have been asked before because we hadn't made these medical advances. So questions around what cloning would mean, could humans be cloned, and so on and so forth. And suddenly our ethics had to start catching up with our technological and scientific developments. In 1995, we had questions starting around biomedicine funding, and the fact that so much of the research in our universities are funded by big corporations who have a vested interest in the outcome of, let's say, the testing of their medicine. And what does that mean for publication? And you'll remember that a lot of the critique of this kind of work was that negative findings were very seldom published. So it's only positive sides. And what does it do to what it is that we do as scientists? And then very famously, and it's something that we saw the aftermath of during COVID, was in 1998, Wakefield's falsified research in which he drew a connection between MMR vaccines and autism. It was proven to be false, but that specific paper had a massive impact on public health, and we can still see it to this day. So the question around falsified research, I mean, up to this point, had to do with personal integrity. But in 1998, we started seeing that this idea of personal integrity also very fundamentally had an impact on the ways in which public health was impacted and had massive consequences. In the 2000s, we started, academics started talking about the ethics around publication, whose names should go onto a paper. The questions here were about an imbalance of power. So very often in some fields, the head of a lab would put his or her name on all papers published in the lab, and as first author. And the question became an ethical question around what it means for IP and what it means for the ways in which we produce knowledge. Who takes responsibility and whose ideas get out there. There's also enormously, well, an enormous increase in the pressure put on universities like our own to train people in ethics and to report on ethical breaches and the ways in which ethics is practiced. And in our case, as you saw, with all these laws that had to do, or that started impinging on the work that we do, it became increasingly formalized by government, and in our case, by the university. So the university decided to register with the government, and therefore we became subject to its guidelines and, very importantly, its laws. So we also have in the 2000s something that we could not foresee, the ClimateGate saga, where the the researchers at the University of East Anglia were hacked by climate skeptics, and these climate skeptics wanted to have access to their data because they wanted to prove that these researchers had made up data, that their data was suspect, and that they manipulated findings on climate change. Now, the ethical question that it brought up was on how well, the ethical question that became very important there was on the security of data. And that's something that we hadn't had to think of before. So again, our ethical guidelines started to catch up to this. So basically, I'm not going to go into Mariana's thing, but what I wanted to say in this presentation was that all these rules and regulations that now kind of determine a culture of auditing, and that this culture of auditing that we can see most pressingly in the ethics applications that we all have to do, has a pre-life, and that pre-life saw many scientists many scientists breaching what used to be personal rules, and it then had to then led to all kinds of rules and regulations to keep the rest of us in line and to make the guidelines much clearer. But as I also indicated here, with each scientific and technological advance, we see new ethical questions cropping up, and I would imagine more laws and guidelines coming our ways, and specifically for people like me and Mariana, more rules and regulations that we have to then oversee and audit. But hopefully, and I think this is something I also wanted to say, hopefully something that we can then use to also protect our researchers. So if you follow these rules and regulations and we audited you, then we also become responsible when your research attracts critique or ethical questions. And it's in that instance that the university then has to come to the forefront and say, well, you've done your due diligence. It is now our responsibility to protect you because of that. So the two sides of this ethical thing, on the one hand, the auditing, but on the other hand, the protection in a increasingly litigious culture. So that's it from me. I'm going to give over to Mariana now to talk about the ethical issues that guide our review. Thank you very much.
Yes, thank you very much to Ilana. I hope everybody can hear me. I'm just going to try and share my screen. We had some challenges this morning. And so, can you see my screen?
Yes.
I can see your screen.
Okay, so I'm going to start immediately, and I'm going to be on the more practical side of ethics review. And just a brief word to say that I am a founder member with my 3 other colleagues of the South African Research Ethics Training Initiative, and we've been training research ethicists for Africa since 2003. And so this is my passion, ethics review per se, but I want to immediately start with why am I passionate about it? I think you've heard from Ilana this morning the history of unethical research that has been conducted through throughout history. It's interesting, the first ethics review guideline that was published around about 1719, if I remember correctly, was actually to guide animal research rather than human research. So we really have to focus on this, and I think that we always have to argue perhaps from our own perspective, because a crucial part of ethics review is really the respect for persons, that we really respect individuals as they come to us with their culture, their language, their background, their issues, and that it is focused mainly on respect. And in that respect, it's also then when we do research that we're actually doing it because we take their best interest at heart, and this is why we want to conduct research. My own history of going into a PhD laboratory-based research was actually based on this respect for persons, where I had a discomfort, because we would say, and that's in the early 90s in Belgium, we'd hang out little advertising pamphlets saying, if you want to earn 60 Belgian francs, please donate 60 mils of blood. And then we would play in the lab with it. I worked on monocytes, my two colleagues worked on the T cells. And in that job, I knew something was wrong, but I wasn't quite sure what was wrong. And later realized that we didn't get informed consent. And this is that started me on the road onto research ethics. So, as you say, then from the 1990s onwards, there's been major debates developing about research being done in research developing countries, because suddenly Africa was a nice continent. You could just come and test whatever you wanted, and there was a feeling that was developed of exploitation, because if you're going to do research, but it's not going to be of benefit to the local community. Is that correct? And so there were major publications and discourse and debates going on about research in developing countries. And so eventually Emmanuel et al. And his colleagues at the National Institutes of Health formulated the framework called Benchmarks of Ethical Research in Low and Middle Income Countries or in developing countries. However, from my perspective, having been dealing with research ethics for the last 20 years, is really a crucial framework to be used by everybody when they are dealing with research. There's, of course, multiple interpretations of these frameworks, and it can vary from contradictory to controversial. However, it is a nice framework to work with and to try and look at your research. And so what are the ethical issues that were at the time being debated that led to this particular document? It was first of all the standard of care, because suddenly researchers would come in with a clinical trial and they'd say, oh, well, there's no existing treatment for this disease in this country, so therefore the standard of care is nothing, so I can test anything against this. And that, of course, is unethical. So that later became formulated into the guidelines, Helsinki and SIOMS and so on, took it on, that you can never compare no available care and call that a standard of care arm. Then also became the issue of availability of medicines and or interventions post-trial, because suddenly you now tested a medicine, you found it, and specifically in the HIV field.
This is the most convenient.
Sorry, can somebody mute?
Excuse me, Mr. Mdladla? Mr. Mdladla, please mute. Thank you.
Thank you very much. So then in the HIV pandemic, we had this problem that they would come and test new medicines, but it would not be available in that particular country, and it would not be available post-trial. And then became the big debate, and eventually the guideline ended up with reasonable availability of the medicines or interventions post-trial to that particular population. We also then started dealing with the multicultural context where research was taking place. For example, how do we get informed consent? What is truly informed consent? What are the problems in informed consent? And I still remember the major issues that were in the 90s existing in China, because the Chinese population distrusted putting their signature onto any document, because you could end up losing all your property and furniture and what to government if you write it. So they would not put their signature on a document, and they wanted the fingerprint informed consent. So these are some of the multicultural issues and debates that led us to rethink guidelines continuously and coming to this. And in the end, there is no right way to do a wrong thing. So there were many issues. So here is Emmanuel et al. He's an oncologist. I'm a pediatric oncologist, so he's quite a nice guy. Done a lot of clinical trials in cancer, and then started realizing about how important research ethics is. Went over and became an ethicist, and he's at the NIH. And he and his colleagues started putting this document together in an attempt to provide a unified guidance for researchers at the NIH doing research within developing countries. And their target audience from the beginning were both the researchers as well as the ethics review committees. And the major issue was to ensure that there's minimization of exploitation. Now, the benchmarks, the framework functions with general ethical values, namely, there should be quite honesty or veracity, there should be scientific integrity, and there should be avoidance of any fraud. But it is a complex process, but we also need to acknowledge that research per se is quite a complex process. So what are these benchmarks of ethical research? It starts off with scientific validity, followed by social value, a fair selection of the study population, a favorable risk-benefit ratio, collaborative partnerships, independent review, informed consent, and respect for recruited participants and their communities. So if we look at scientific validity, and I think this is one of the major issues that we always have in ethics review, and I specifically want to sort of highlight problems with the postgraduate research studies, master's and PhD levels, because the first issue that we look at any protocol is there scientific validity, because that's an essential ethical requirement. And when we look at it, we look at the title, we look at the question being asked, and we look at the aims and objectives. And so the title, the aims, objectives, and the question should actually ensure that the objectives will answer the question. So the design should be in such a way that the objectives will be achieved. And it should generate useful information. There should be benefit eventually, either for the class of participants or for the individual participant per se. So somebody should benefit from this particular research. And we want to minimize research that is not going to lead to any benefit. For example, you want to count how many telephone poles are red or green, but you're not going to do anything with that information. It doesn't help anybody. Then you look at the community, whether that is particularly feasible in the society where you are going to do the research, and will it be able to generate an answer to your question. So you're definitely not going to ask in a closed community of very religious behaviors, you're not going to do gender issue research because they will not be open to that kind of research. So it has to link, the context must link to the community or society. And very often you need to require education of the staff, research staff, and with constructing of additional facilities or provision of medicines or interventions. And I must say, some of you that are on healthcare research will know that KEMRI in Kenya is very strong on research in Kenya. But what you often find there is you get this brilliant, fantastic hospital and laboratories for those who are embarking on malaria research, and right next to it is a very dilapidated local clinic for the rest of the diseases. And it's always a bit really awkward to visit, because you see on the one hand this fantastic facility, and on the other hand the local facility that's just not nice for the population. So one has to look in the protocol at all these issues for scientific validity. Then it must be of social value. So whatever new knowledge we're going to generate should be beneficial to the communities. And now, as I'm in medicine or in healthcare, it should lead to health as improvement of health as an example. Now, very often, if you start with early studies, and here I'm talking specifically, maybe it's a good example, phase 1 studies with medicines, you want to see eventually create generalizable knowledge for that potential class of participants. So you want to see in phase 1 and 2 studies, will this group of patients potentially benefit from this particular medicine? And then in later studies, you have to prove that there's individual benefit for that particular individual. And that's usually the phase 3 studies, where you now say, this is the disease, I'm targeting this disease, I'm giving this medicine, and there should be improve or cure of this particular disease for this particular individual. And also post-marketing studies, which are the phase 4 fit. Very often when you start with your research question, you have to acknowledge during this process that it can be very uncertain You may have a hypothesis and you think this is going to work, but it is uncertain in the planning phase, and you have to acknowledge that and build that in and reflect on that uncertainty and let that also be discussed in the protocol. And it's especially problematic when you are going to do research, as I've just given an example of chemistry and malaria research in Kenya. If next door you have this underdeveloped infrastructure, or the infrastructure cannot cope with the type of research that you want to do. So one should really look at making sure that you link your infrastructure to the research that you're going to do for social value. And so always there's the 4 key questions. For social value, who will benefit? Will it be truly those individuals in this particular community? What is the potential value for the beneficiaries? Do they want to be treated? And I remember a very good example of one of my students for a master's in research ethics in Sareti. He was living in Burkina Faso, and he was very uptight and upset because they were doing a lot of HIV clinical trials in that phase, but where the biggest problem for them as a healthcare issue was malaria, and that very, very few HIV studies, HIV patients, but they had many HIV studies and no malaria studies. So there should be the potential benefit, the community should benefit from what you are going to do. And then you need to look at the mechanisms that can enhance social values through the collaborative participation with the community, and also later in the dissemination process, so they also know what benefits were there from this particular research. And it should never undermine, in our context, existing services. And a nice example is healthcare services. So if you're going to do healthcare research, it shouldn't undermine the existing public health services that are there. It should actually enhance or be an extension of. And then we come to the fair selection of population, and that is really a problem that we often find in research protocols, that the study population you select as a researcher should lead eventually to scientific validity, and at the same time risk should be minimized. So one of the nice examples that I want to mention of unfair selection that I've seen in my career is where they were going to test a specific medicine on a specific group of patients, and they were all having, say, for example, peptic ulcers. So they wanted to test a new peptic ulcer medicine, for example. And then they said, oh, they're going to recruit all patients with peptic ulcers, but excluding those who cannot read and write. Now, on what basis can you exclude that? And especially in the context of South Africa, you cannot exclude patients because they're illiterate, because they cannot doubly pay the price for a historical background where they did not have access to education, and now they have a disease, but they may not benefit from something that may potentially be of benefit to them. So one should really think in terms of it. Or what I often find is, no, they're not going to include, they're only going to do the study in English because their documents are in English. Now that, and again, if you're in a community where there's multicultural context with multi-languages spoken, you have to adjust and make sure that all language groups are accommodated. And we always guide in the Western Cape province that we should use at least the 3 most commonly spoken languages in the country. If we do national studies, of course, you have to go to 11 languages if necessary. And in this process, you should look at a population where you can minimize the risks to the extent possible. Again, it's very important, and I will come back to this later, the collaborative partnership with the community to ensure the social value of the outcome. And you should ensure prevention and consideration of other issues such as familial or professional coercion, or those that are already socially marginalized that can become more marginalized through the research process. And we have to acknowledge that the participants can often be or are often politically powerless in this situation, and there's a power relationship between the researcher and the participants, and one should be sensitive to this potential power relationship. And then there's also those with economic deprivation, where you make actually worsen their scenario if you now start doing a study and you expect them to come very regularly and miss work, etc., because of participating in this particular study. Just one word back. About familial coercion, we know that we live very often in societies with male domination, and one has to make sure that there's no coercion of female participants in that scenario, just as an example. The next one is a crucial one for me in any ethics review process, and that's a favorable risk-benefit ratio. So you really have to weigh what is the perceived benefits and what is the perceived costs or risks to the participant. And remember, we're talking here about potential, because at the time that you embark on research, you don't know what is going to be the actual outcome. So it's a crucial task for anybody involving humans in research, whether it's the researchers or the ethics review committee or the sponsors of a particular study. And the risk should only be justified by the potential benefits that the participant may gain from those research interventions. And in actual fact, the benefit should always outweigh the risks, unless there's a reason for social value justification for the risks. And so this should be favorable in the context of the participants live in, and also for the communities. And this is quite a crucial task. There's many models. How do you address risk-benefit ratio? How do you measure this? There's all sorts of mathematical and algebraic type of thinking about it. But I think common sense prevails. And I think one has to really think of it. And this is why, in a sense, researchers also submit their protocol to an ethics review committee, because sometimes you may be quite subjective in looking at, because you really want to answer your question, you think it's really going to have benefit, but you don't always think of the broader context. And we all know that we are all subjective, and we try to be objective. And then you get to an ethics review committee, and there's quite a number of members, and some of them may perceive something else that it can be a risk, and one can debate and come to it and sensitize the researchers to it. And very often, the most common one is that researchers underestimate is the potential emotional risks, especially in social science context, that may develop and which should be addressed for the participants. But in healthcare, the other one is, if I'm now doing research on malaria, I may be dealing with a patient with TB. Now, I can't say, well, I'm just doing malaria, so therefore, here's your malaria tablets. You participant, worry about your TB. I have to take that up because it's within my field of expertise to also worry about that other disease that the patient must have, and I must arrange ancillary health care for that particular condition. So these are the kind of sort of issues, on the one hand, social science with emotional or suicidal or depression risks, and on the other hand, in healthcare, very often other comorbid conditions that may impact on the participant's life. So then coming back a little bit to the collaborative partnerships, now this is really where we need to identify the potential stakeholders in the particular research project, and that can include the researchers, the sponsors, the local communities, and then the participants themselves. And it's very important that this collaborative partnership is established and respected and fostered, because it is very important for us to always have the public's trust. That trust relationship is crucial in a community, and Ilana has given a very good example of a small town who lost their trust. And we know at the moment very often we are dealing with a public who is distrustful of university researchers, whom they call the ivory tower researchers, and do not know what it's like to live in the community. So we have to foster our partnership with the communities to ensure that we have their trust and that they trust us, that we will act in their best interest. And so for this particular collaborative partnership, there should be representation of all, there should be good communication, always, there should be mutual respect. We should look at ways of minimizing disparities, and that research should actually lead to fair benefits to the community with a fair distribution of the rewards. And this sometimes can be quite complex. For example, if we now think about research involving tissue, and I remember one of my other, again, ex-trainees in research ethics from Kenya said there's so many genetic material being exported from Kenya to the US that they can probably put together about 200 Kenyans in the US on their samples. So they did not see this as a fair distribution or fair benefit to the community exporting all these genetic samples to the US. So one has to make sure that you keep the trust relationship. I come to the informed consent, which everybody discusses all the time. And again, it's basically starts off with respect for persons. And I think we can all investigate ourselves and know that we want to have the respect of another person. And I also want to be respected for my choices. So I want my autonomy at all times to be choosing for yourselves. And those of you who read the newspapers and the SNJ will know that recently we published that also there should be a right to decide how to die with dignity. And so these are all being part of the respect for persons. Now, in the context of research, it's always a first-person consent that we're talking about, and it should be there for all participants. However, we may be dealing with persons that do not have the necessary capacity for whatever reason and are from a vulnerable population, where we may need a third-person consent. But then it's crucial from my perspective as an ethics review member or chair that there's an emotional tie between the third person and the vulnerable participant. Because if there's not an emotional tie, how do I really know that a third person is informed consent is really in the best interest of the participant? And I just want to use the example that we've seen in reality TV, that very often you put a husband and wife team in separate rooms, and you say to the one, what is the favorite color of the other? And this one says red, while the actual person says, no, it's yellow. So those kind of discrepancies between persons living intimately together can exist. And this is why it can even be more important in informed consent to have to make sure that the person acting on the participant's behalf is really, truly emotionally tied to that participant. Then it's also really at how you're going to recruit. Your recruitment strategy is crucial in the informed consent process because you should be respecting the local culture and traditions of the community and find ways of dealing with it. And I always have a discomfort, and I can share that for the social scientists. If you suddenly say, no, I'm going to recruit in schools, but if you're going to recruit in schools, for example, those children that are orphans, you may run the risk of actually stigmatizing them through that strategy by going to school and says, oh, all orphans, please come forward because we want to do a study with orphans. Then everybody knows that that child is an orphan that may not be known and maybe stigmatizing. So one should be really careful about how you think about your recruitment strategy as part of the informed consent process, because this is a process. Then at the same time, you should look at the discompensation, and this has become very, very important in local context because it can range from being expected to range to being offensive, and you really have to know your local culture to understand what is best. Now, in general, in South Africa, we look at compensation that it should be according to the out-of-pocket expenses for the particular person, and that is also still part of the respect that you show this participant, that you are going to give up your time to be part of my research, therefore I'm going to compensate you for your out-of-pocket expenses. Then crucial to the informed consent process is, of course, the disclosure of all information from sensitive, but sensitive to the culture in the community. Now, it's interesting that it varies how much information should give, and very often you hear what laypersons who do not understand these difficult concepts. Then we should find language that we can explain in layman's terminology this information. And it's interesting when the German guidelines, they would say that if a complication of a medicine is even 1 in a million, you have to disclose that in the informed consent. So there's varying issues, and it should be sensitive to culture, but we should make sure that there's understanding in layman's terminology. When we plan this, we should perhaps look at the culture of the community, sit with the community boards, make sure that we understand what is acceptable to them and what's not acceptable, so that you do have sensitivity in your informed consent process. It's always important to have an independent observer to ensure the voluntariness of the consent. And again, I want to share some of my examples. I mean, in my career as a pediatric oncologist, we often do pediatric cancer trials, and we had a trial going for refractory cancer medicine, and this is where the cancer would not respond to any other medicine. And it was interesting, I had two mothers. One was a high school teacher, and she said, no, she's got to go to a community. And the other one immediately, who was completely uneducated and illiterate, and the mom said, no, please, you must do it. And one of my concerns at the time was that I'm seen as a doctor and I'm seen as a person of potentially having this wonderful ability to cure everybody. So I referred this actually to completely independent team to redo the whole informed consent process to ensure that the mother truly understood and truly wanted her child to participate. So it's really crucial to think in terms of having an independent observer because, again, there's a power relationship between the researcher and the participant, and you really want truly voluntary consent from that person. And again, in healthcare, it's very problematic if you're the treating physician as well as the person doing the research, because they see you as a doctor, and we have to acknowledge that in this. And so the independent observer is really crucial. And then very important to document that the individual may refuse or may at any particular time to decide to withdraw from the research process. And that again is respect for persons to make sure that their wishes are respected at all times. So then we come to the independent review, which is really the ethics review process. And this is actually a major aim is to ensure that there's public accountability and trust. We want the public to trust us and say, well, they are acting on our in the best interest of our participants. And this process should be transparent, so everybody should know exactly how we came to the decision and why the decision is making. And the local ethics, all ethics review committees are actually, even though they link to the university, they're independent. And that is very crucial because we should not be having any interference from any authority. So it should not be the vice chancellor coming to say to me, listen, we want you to approve the study because it's in the interest of the university. It should be completely independent from any interference from authorities. Then the reviewers should be competent, and they should have a knowledge of research ethics and of science, and therefore they should be trained in the ethics review process. And currently the standard is, in our context, in Faculty of Health Sciences, Medicine and Health Sciences, is that our members should have undergone the 3 modules, which is an online research ethics training program developed by Dominique Spermonti and his team, and we all participated in the South African module. And so it has an introductory module, and then it has a South African dedicated module. It is in several languages. It is now dedicated, developed for most countries. And this is an online and really good. And I just want to say that the new South African module should have been released last week or probably this week. But it's a very good way of being trained in ethics review process itself. And then there's different models for research ethics committees to do their research. Usually, traditionally, the model is to reach consensus. So reviewers will review the protocol. They will present it in the meeting to the whole committee membership, which usually should have a quorum of 2/3. And then there should be consensus. And any disagreement should be debated and until consensus is reached. And sometimes other committees may opt for a voting process. Most of our committees function on the consensus agreement, and disagreements are discussed until we reach consensus before it's sent to the researchers for their knowledge and their modifications if required. So coming back again to part of the respect for persons is also respect for the communities. So we have, as the researchers, obligations to participants, communities, and former participants, where we especially look at confidentiality issues where purposes should be respected at all times. But also we have the other side of the coin, namely that once we've got the information and we've analyzed and we now know what the benefit is, we should find a way of sharing this information with the communities. And crucial to this is if there's a change in the risk-benefit ratio, especially during the research process, this should be immediately communicated to the participants so they know about it. And all adverse events should be monitored and addressed, and this information should also be shared with that local community. And I come back to the one point that I've already mentioned, namely ancillary care. If we are doing research with, for example, now I'm going to use tuberculosis. We are doing tuberculosis, but in the process, we identify this person has hypertension or diabetes. I can't say, listen, you've got to go to your GP and sort it out. I have to make sure as a healthcare researcher that I refer this patient to the appropriate person for ancillary care. So when we look at the research protocol, we look at what ancillary care may be needed. And in a sense, this is very true for social sciences. If you are, for example, doing education research, you want to see a new tool is helping the learners to learn easier, but you suddenly pick up ADHD, you have to make sure that you then have arranged ancillary care. Or if you are doing research about depression and you suddenly realize this person is suicidal, you have to have ancillary care immediately available that will address that crucial risk of suicide behavior. So those are the kind of things and how we respect our participants and our communities. Now, there are objections to this framework, so I have just phrased it into three categories. One group of the critique is that it's too complex and that it creates barriers against research. Others argue it's already in the current guidelines. It is in the Nuremberg, it is in the Belmont, it is in the Helsinki, so why need another separate guidance? But the one thing about it, and the third group will say one must realize that even if you apply this framework, that disagreement may be possible. Just sort of saying there are never a complete, absolute truth in this. There's always complex. It has to be debated. It can be used as guidance. I think it's quite useful in the South African context, but have to acknowledge that this agreement may be possible or may have to be adjusted according to local situation or research process. Ilana has touched on it, and I'm just touching again on it. We are living in an extremely regulated framework in South Africa. First of all, there's the South African Constitution, later the National Health Act, number 61, the Department of Health 2015 Ethics in Health Research Guidelines, which are being updated, and we'll soon see the 2024 version. Helsinki Declaration is currently being updated. There's quite a number of new issues that are developing. We have the Belmont report, which actually led to principalism, which is now the common bioethics approach when you are dealing with human participants or with in clinical medicine. There's a SEAL guidelines, there's good clinical practice, just some of the important guidelines within this. And I'm just going to sort of focus on the 2 or 3 points per document. Now, the South African Constitution already in Chapter 2 says everyone is equal before the law and has the right to equal protection and benefit of the law. And this, in a sense, is then also against practices in research that may pose quite severe risk. And then everyone has the inherent dignity and right to have their dignity respected and protected, and everyone has a right to privacy. And we all know that this is one of the issues that in ethics review often is being pointed out to researchers, that there's a lack of right to dignity or right to privacy and so on. And this is especially when it comes to informed consent and waiver of informed consent, where everybody wants to ask a waiver of consent, but then you have to prove as a researcher how you're going to make sure that you are anonymously analyzing the data and that the participant will never lose his or her right to privacy. Then there's the National Health Act, which actually established the National Health Research Ethics Council, which nowadays accredits ethics review committees around the country to be able to do independent ethics review or not. They are also there to guide the research priorities of the country. So that's annually debated in the national and provincial departments of health and to set research priorities. And then specifically in the context of research, then that you can only do research with written consent of the person after he or she has been informed of the object of the research or experimentation and any possible positive or negative consequences on his or her health. And then furthermore, it deals also with research involving minors. And please note, legislation requires both parental and minor consent with additional ministerial consent for non-therapeutic research. Now, fortunately, these acts were promulgated, and they did not realize how often we are dealing with non-therapeutic research. For example, I just want to look at how many children are right-handed or left-handed. It's non-therapeutic research. It doesn't pose any risks to them. And so that was now, fortunately, through regulations, now with the local ethics review committee having that consent. They can give consent for those kind of non-therapeutic research. And then the last is that every institution or health agency and health establishment at which health research is conducted must establish or have access to a health research ethics committee, which is registered with the National Health Research Ethics Council. So you can see that we are within this legislative framework of dealing with research, and we cannot move outside of this. Then I just want to briefly look at the ethics review process, and I just have here at the bottom our book that is free of charge, downloadable as a PDF, Research Ethics in Africa, a resource for research ethics committees, but it's also useful for researchers. And just some background how this book came about. It was our postgraduate students doing a master's in research ethics from all over Africa who kept on saying, oh, it's all these Western guidelines not applicable to Africa. So we came together in a workshop, debated the issue, and decided to write this textbook that is specifically aimed at Africans and looking from an African perspective. And in that time, I had three types of reviews: the standard review, the expedited review, and the continuing review. And now we've added one after the COVID pandemic, which we call the urgent review. Now, the standard review is which you all know, where you write your protocol, it's submitted to the ethics review committee, they review it, they give you feedback, and you respond. And then there's the expedited review, and this is usually for research that is of less than minimal risk. So, for example, an audit study, I just want to check how many students did take this course in the last 50 years and how many passed, and that is without any risk, and I can do an expedited review, no access to participants. And then there's this research that needs continued review, for example, clinical trials over a 4 or 5 year period of time. There's continuously progress reports coming in, and that look at to make sure that there's a continuous review process. And then we now know that when we have suddenly an epidemic or a pandemic, as we've had with COVID-19, with novel medicines being urgently developed to address the disease, we now need to come to urgent review. So it's quite a process, and it's quite a long deliberation in these meetings in general. I don't know of social sciences, but we usually can end up with a 4 to 5 hour meeting of the protocol submitted of the day. So just a brief word on the research protocol. What do we look at when we look at your research protocol? We first of all look at the literature review that is summarizing previously related research. And this is really to say, what is the existing knowledge that is out there? Then we look at the research question, and this should really pose of what is going to be novel. What do you really want to develop now? And then you're going to say, what is the aim and the hypothesis? You will come with your specific objectives that you will do. And then you will look at the scientific valid design. And this again, I want to urge you who are supervisors of postgraduate students, please guide them in developing a scientifically valid design. It is very often where we start off giving quite a lot of critique on the methodology. Then you look at the sample size, whether the study population is the correct study population, whether it will be equitable selection and fair selection of the participants. We look at the inclusion and exclusion criteria and make sure that vulnerable populations are protected. We look at the data and statistical analysis plan. We look at the duration of the study. What is the recruitment strategy? Is it appropriate? Is it friendly? Is it respecting persons? We look at the informed content process. We look at how confidentiality and privacy will be respected. And we look at whether the researcher has the necessary qualification, therefore namely having the proven expertise in the proposed field of research. And then the final, most crucial task, the careful risk-benefit assessment. We really want to see there's more potential benefit than there are potential risks. So I decided to pick 2 issues added to this topic in comparison to last year of issues that developed during the past year. There was lots of debates going on. And the one thing is consent of minors, especially talking about the adolescents, where very often researchers come to us and say, listen, adolescents can decide for themselves. And we, in actual fact, know that by very often 14-year-olds have exactly the same deliberative ability to understand the research question, to be able to deliberate the consequences of it, and can give consent to the same extent as adults. And that is even true for those that are 12 years and not younger, 12 years and older. So although sometimes 12 years and 14 years still have issues with long-term deliberation. However, and we know that they can say yes or no to medical and surgical treatment from 12 years onwards in South Africa. So when you are dealing with this kind of research and you want only adolescents to provide consent, there's this very good paper, and there's several others by also by Anne Strode and Kathy Slack, but this one was recently in 2022 in the Southern African Journal of HR Medicine, looking at this, where this particularly comes from a group dealing with HIV/AIDS research. So you first look at the justifiability of inclusion of minors. Is it justifiable? And then you look at whether a waiver of parental consent is necessary and justifiable. And we know that sometimes teenagers don't want to share all their information with their parents. Therefore, you need to look at it. So the next thing will then be at the risk. What are the potential risks? How can these be mitigated? And if there are risks, do individual or general population benefits outweigh these risks? Then we come to the community participation, where we go to the community and say, we want to do this research with adolescents. We think the risks are minimal. We think it can be mitigated. We don't think the parents have to be involved. Do you agree as a community? And then you look at possible solutions with SOPs and study designs and types of consent, and you then engage with the ethics committee. And it still stays a pretty clear, because it comes back all in and all again, and because researchers will say, but it's really not necessary that parents do this and so on. From my perspective, and this is just a personal opinion, first of all, we are having, unfortunately, the legislation, and many of us in this group that are now talking about adolescents are trying to impact on regulations and legislation, because in actual fact, the guidelines, the Department of Health guidelines, say that if you think it's minimal risk and it's going to benefit the participant, you can have a way to adolescents. But this is outside of the legislative framework of the National Health Research Ethics, of the National Health Act. So there's controversy about it. So really, one has to really carefully go and reflect on what are the risks. And I always argue that the minute there are risks, you have to remember that the parents are the ones that's going to look after the adolescent if the adolescent suddenly develops a complication because of participating in research. If that is the case, then you have to involve the parent. Now remember, the parent doesn't have to know about the sexual activity of the child if the child doesn't want to disclose it, because they have the same right to respect for privacy and confidentiality. However, when it's research, it's not a normal practice. I think one has to be very careful to want to exclude parents, but there's these kind of things that you can use and read about and see. And there still is currently a major issue with quite a range of debates going on. Another one that I just want to say at the moment, I have not decided not to include artificial intelligence as well, but partially it comes up with biorepositories and data banks. And so I thought this article in Academic Medicine of 2022, and I'm quoting literally from it, has some very good guidelines for those that are creating biorepositories and or data banks. It states that the assessment it should have 4 criteria. The specimen to collect, whether it's leftover new collection or add on to clinical test, can be put there, but we should have an opt-in or opt-out consent process. You need to know where you are approaching the patients for this. You need to effectively use digital tools for consent. There must be consent for this, and we must simplify the consent information for layman terminology. So it's quite a huge issue at the moment, because everybody is creating a data bank, and it's also important to start reflecting who's going to have access to the data bank, and if it's for the biorepository, and you have to have this in the informed consent. You have to decide what you're going to collect, what you're going to add, how you're going to opt in or out, how you're going to ensure that the participant who is donating material or data is understanding it, and given how to approach them and how to make sure that they understand all the information. And of course, and we know it's rapidly, the human genome sequencing is rapidly expanding, and there's a huge UK biobank, and this is being used to develop new medicines. So we are, in a sense, also need to be altruistic in our sharing of our genomes for this particular person, but of course it has to weigh against the privacy and the confidentiality of the person, and also what kind of benefit eventually should come from it. So those are some of the major two issues at the moment, and that brings in also, in a sense, artificial intelligence, because that is used to go into these huge data banks and then create algorithms to understand certain diseases or address potential interventions that are usable in the interest of participants. So it's going to be with us for quite some time. And so with that, I just want to conclude that the main aim of research ethics is only about the safety and respect for persons. So we need good science which can generate good facts and that will lead to benefit for the participants. And that is what good ethics is all about. Thank you for your attention.
Thank you so much, Professor Kruger. That was a good end to our session in terms of that good science equals good fact equals good ethics. I wonder, colleagues, I know I've been asking for people to post your questions in the chat, but we've now come to the end of the session and would like to hear from you. If you have any specific questions to Prof van Wyk or Prof Kruger, please raise your hand. We would like to make this as interactive as we can. Or their presentations were as brilliant as always, and everything has been made clear to you. Dr. Janine Marais, please go ahead. You're welcome. Okay, so I have Dr. Janine Marais first, and then Ms. Suzanne Tonsing after. So Dr. Marais, please go ahead.
Hi, thank you so much for the very informative presentation and also the background information of how it developed over the past decades to where we are now. So I do research involving participants, either consumers or we have a trained sensory panel at the Department of Food Science. And we have to start this process fairly early in the degree process, so with master's and or PhD students. So it's sometimes an issue in the faculty to get a good, because the students are still developing their proposal until May, but we have to get the ethical clearance in before May, far before May, because we have to start doing that research. So to what extent do you need that literature review? Because sometimes we highlight things, but there's not often time if you have to start to submit that in February to also have that literature review. So the aim and objectives are well formulated and what the outcomes will be and the methodology we have in detail. But that literature review part, to get the student to do it as part of their learning process and to not have it fall on us, but to also get the application in ASAP.
Janine, yeah, thank you very much for your question. Yeah, I think, we all, because both Mariana and I and everyone on the ethics committee, we also teach and we also have students who go through this. And the question here is, how can we get it done quicker and can we get rid of the ethics, the literature review? Problem with that is that we then miss out let's say I'm on the other side having to review that. I cannot see whether this work has been done. So if you don't give me a research literature review, I cannot see whether you are going to waste people's time, and that's an ethical question. So if this research has been done and you just, kind of flexing the training muscles, that would actually be unethical research, and that is why we need some kind of literature review. In my own field, it doesn't need to be extensive. It just needs to show, look, I've read, this is the general work that has been done on this field. These are the protocols that are accepted, whatever else, and then go on. So it's actually that little bit goes towards scientific validity. And scientific validity is an ethical question, but so is the question about respecting the time that our participants give to a project. And if that time would be wasted because the research has been done, then it would be unethical. I don't know if that answers you, Janine.
And I just also respond by saying that I think part of the training well, first of all, we have to look at novel questions. So it's really, you cannot, a short summary of literature review is crucial. And I think in the interest of assisting your students, because of the tight time frame, is rather to have a data bank of publications per topic, which will assist them because they come in and then they know, well, I can go and look for it. Although on the other hand, I'm one of those who say that when you come to university, you've already been through school and you've been learning how to put projects together, and you can do it. And I mean, even if you want to submit an article for publication, you have to give the journal a short, brief reason of why did you want to do this particular question. And you have to say what is new, what is old or known information, and what is your new aspect on it. And this can be brief. None of us expect, I usually tell our master students, because it's compulsory for those who are specializing in medicine, to have a research protocol. Now, most of them want to be specialists. They don't want to be researchers. But in order to become a specialist, they have to do research. And so I usually say, well, I don't want more than 1,000 words, but you've got to write me an essay. And they've been through school for 12 years, and they've passed matric because they can write essays. And they've been having an undergraduate degree because they can write passages. So I don't think a 500 to 1,000 words, you need to decide what you think, but there must be demonstrable reason for the scientific validity of this particular study. Thank you.
Thank you. Yes, that does answer my question. Just to know that it can be brief. It doesn't have to be pages. Yes, thanks.
In actual fact, I preferred. I want to update our SOP to make sure that it is, because reviewers having to read 90 pages to summarize in one sentence what you want to do is also ridiculous.
Yeah.
We next to have, yes. Suzanne, please go ahead.
Suzanne, you might be muted.
I just want to say, Gadamer said, if you have studied for 20 years and you can say it in a nutshell, it's fine. But if you cannot, go back and study another 20 years.
Suzanne, you may go ahead.
Thank you. I just wanted to ask you for a link to the papers. Well, not a link, but maybe again just put in the chat the authors of the papers that argue against assent and consent of a 14-year-old and older, because I think that is a very, very important point. And I think it is really probably why it's so difficult for us. I mean, I've worked with clinical trials in TB research and, well, actually all kinds of research, but it's medical research. And it's difficult for us to get teenagers to join the studies, for one, because they are in school, but also, I assume, because they do not want to share stuff with the parents. And I think that's a valid argument. Thanks.
Is it specific here about the adolescents? I'm going to put in the chat some of the names that you can look at who's published. They mostly from KwaZulu-Natal, because they've been doing HIV research and ethics issues for a long time. The publication I've got, and I've said to Clarissa, she can share my presentation, because that has that recent 2022 article in. And then I think one also look at the National Department of Health 2015 guidelines and look out for the 2024, because I think that is going to address this in more clear detail. There's quite a lot of debate, and one of our biggest issues about this is that once you've got legislation, your regulations is really difficult because you are within that framework. And we just take this adolescent thing, and especially Anne Strode has written very well on it. I mean, she is a legal, she's a professor of law. So you have the Children's Act, you have the Termination of Pregnancy Act, you've got the National Health Act, and then you've got the research issues. And all of them are not in agreement with each other. Because the Children's Act says children of 12 can say yay or nay without their parents. And the termination of pregnancy any age. But the National Health Act says must have parental consent. And that's where the crucial issue is. So I've now put those in the chat. I hope you can see the chat. Why don't I see the chat?
Yeah.
There it is. So those are the two important. There's several others. And then look at the guidelines. It's really about this. For example, if I'm going to do a new cancer medicine, or let me rather put it, a new HIV medicine, and there's potential risk of increased clotting, how am I going to exclude the parent who's going to have to look after this patient if this child develops an infarct with cerebral palsy? And that's always sort of what I'm trying to argue. On the other hand, if I'm going to do research on the use of condoms, I know children do not want to tell their parents where they're sexually active. So clearly I don't want to involve the parents, but I need to involve them to say that I'm going to do research and I'm going to do a questionnaire based with the child, and I'm not going to give you the answers because it's their privacy, their confidentiality. So it's really about a risk-benefit assessment again. But please read these authors. There's quite a lot of them. Thank you.
Thank you.
Risha.
Hi, thank you very much. It was a wonderful presentation, as always. Mariana, I just want to find out, you mentioned about adolescents. I just want to find out the age range. Is it from 12 to 18? And if you would want, if we work with a pediatrician who sees children lower than 12 years, how low can you go? What is the lowest age for a study? And obviously I presume that under 12 the parents will always have to sign. That's my one question. And then my second question is, if you do obtain data in your laboratory, Mariana, you mentioned if you get a funny or a high CRP level, or a level that's higher than normal, and you are worried about the patient, that you will be able to share that data with the clinician. What happens when you have purely research data? And in my instance, I'm talking about data that perhaps is not yet mainstream, microclot data, for example, which we collect in the laboratory, but it's not a pathology test. Do we share those type of results too, or do we just not share that? Thanks.
Okay. Can I just first of all say, legislation is very clear. The National Health Act says you're doing research with minors, and minors in South Africa context are persons under the age of 18. So 18 is actually adult. So you have to have parental consent. That's just the bottom line. The problem comes when you are wanting to work with adolescents and they actually can decide for themselves. So there is no exclusion of young age, because there's certain conditions you can only do in neonates, so neonates are being included. But so that's the guideline, and I think if you just on the letter of the law goes, it is everybody under 18 years of age should have parental consent, period. Coming to the ancillary care, if you are posing a very difficult question, because your microclots is not yet standard of care abnormalities in clinical practice. But I think it would be advisable to discuss with the clinician treating the patient who has a relationship. Remember, this is also crucial. There's a relationship between the doctor and the patient. To then share the information to the extent he or she thinks appropriate and to act with it within his or her context. It's very difficult to completely say, but I, for example, would want to know if I have a potential patient with a risk of clotting, and I would then go and look if they, for example, von Willebrand disease, protein S or C deficiency, because those are more common conditions that are not necessarily tested in the general population. But if I now hear there's a problem, I'm going to look more carefully at that person's clotting profile. But that in a sense is what I can answer at the moment.
Okay, just one last question. If you've got a biorepository in a database where you get samples from a patient, but you're not allowed to contact them afterwards, is that something different? If so, with the informed consent, you get samples.
If your biorepository is set up to have anonymous databases, you can use it for future research. Then you cannot trace the patient, because if it's anonymous, it's anonymous. Then so unfortunately,
in that case,
you can't act on it.
Okay, thank you.
Okay, thank you very much, Prof Kruger and Prof van Wyk. This has been a very informative session, and I'm sure, colleagues, that your questions were answered. I know that we ran out of time, and if there are any questions, please contact the relevant research ethics officers, and we will make sure that your question is answered by one of our research ethics committee members or by someone within the office. Thank you so much for your time, Prof van Wyk, Prof Kruger. As always, we always have information and we learn more whenever we engage with you. So thank you so much for your presentations. And everyone, we look forward to seeing you at the next session, which will be more on the procedural aspect of how to apply and what is required when you submit an application to ethics. Thank you so much, everyone.
Thank you
Have a
very
good
much.
afternoon.
Thank you very much.